video presentation, Selected Best Practices in the CHIA Community, a panel discussion. We've made every attempt to provide insightful and accurate information and also give you some new ideas from our panel today. We're offering practical and useful information and tools, but your results really may vary in your organization. This presentation contains no PHI, and any data that's discussed is purely fictional. This will be a panel discussion on the unique HIM best practices in our CHIA community. The panelists were interviewees for the forthcoming CHIA EMPI Toolkit, written by the Health Information Integrity Committee. We hope to see that published later on this year. This presentation hopes to bring some of the more unique ideas from our community to help improve the health data for all of our members, to protect both our patients and our organizations. Our panelists today are Adrian Beauvoir from City of Hope, Larry Smith from Pomona Valley Regional Medical Center, Marilyn Liddy from Adventist Health, Tara McClellan from Sutter Health, and Diane Primo from San Francisco Department of Public Health. Hi, I'm Jim Hoover, your moderator for today for Selected Best Practices in the CHIA Community. This panel discussion was pre-recorded, but the panel and I will be available at the end of the video to answer any questions you have, as well as probably add some additional commentary from the live discussion as we think of additional topics or ideas. The panelists were selected from interviews I did for the EMPI Toolkit that CHIA is going to publish later this year. It's really great content, and the entire committee, the Health Information Integrity Committee, worked really hard to bring it to you, so I hope that you enjoy it and find it valuable. The interviews were so inspiring from this group that we decided to make the content available in this form, panel form, and we can thank Larry Smith for that idea. It was a really great one, and I'm glad Larry had the idea to present it to you in this manner. In selecting the panelists, I wanted to bring out really a bit of diversity in the CHIA community from an organizational perspective. We have large healthcare systems, a large government healthcare system, Department of Public Health, and a regional medical center, all with very different perspectives on data integrity, and all with great ideas that I think you will enjoy. Each panelist had at least one unique idea that I think the entire CHIA community could benefit from hearing about. So without further ado, let's get into the panel discussion, and I'll see you at the end. Let me ask the panelists to introduce themselves one by one, just your name and maybe your title and where you're from. How about you first, Adrian?
Well, hello there. My name is Adrian Beauvoir, and I am the Executive Director of Health Information Management at City of Hope.
Awesome. And Marilyn, how about you next?
My name is Marilyn Liddy, and I am a Senior HIM Manager at Adventist Health Corporate Office. And one of my teams, I oversee the data integrity.
Awesome. Tara, you're next.
Hi, I'm Tara McClellan, and I am the North Bay HIM Manager for Sutter Health.
Awesome.
I'm also Jim's cohort in the Health Information Integrity Committee and the EMPI Toolkit in particular.
And then Larry, how about you, sir?
Well, thank you for inviting me, and thank you to all the other participants. I am Larry Smith. I am the Director of Health Information Management at Pomona Valley Hospital Medical Center.
Awesome. And then Diane, we'll leave the best for last. How's that?
Hi, my name is Diane Primo. I'm the Director of Health Information Services for the Department of Public Health in San Francisco, California. And currently we have a huge focus on population health. And of course, the pandemic has definitely challenged everything from data integrity to positive patient matching. And so looking forward to this panel.
Awesome. Well, thank you guys, everyone. I really had a great time during our interviews. And when it came time for selecting everyone for the panel, I was so happy that all you guys had said yes. So I really appreciate it. And let's get into it. So first, I'm going to pick on Adrian, because Adrian and I have had this long running discussion on data audits for well over a year now. Kind of from my perspective, I've seen City of Hope to be a bit unique in the expansiveness of their data quality audits run by her team. So it's kind of interesting to me to understand how the audits can lead to improved quality, data quality. And I'm hoping that we can understand the goals and benefits that City of Hope got from implementing this quality program. Welcome to the panel, Adrian. Would you mind telling us an overview of the City of Hope audit program, please?
Yeah, so it's actually part of our HIM department. We have a section called Operations Support. And I have a manager, a senior manager in that section, and 5 analysts. And so really they're tasked with all things related to audits and reporting for HIM and for the Registration Information Governance Work Group or Committee, which we in HIM started a couple years back. Because we knew basically that there were opportunities to improve the quality of the data collected. And as you said, you know, City of Hope, we have our medical center, but we also have the 30+ community sites that also touch the data, you know, in particular the registration data. So we found the need to sort of corral that process and do audits and provide feedback on the quality of data collected. A lot of our efforts at City of Hope are related to research and philanthropy. So there are 2 huge arms in our organization, and they so critically rely on the data accuracy. So this has been been a great win for us and for the organization.
Adrian, how do you guys determine what to audit? I mean, it's a a lot of data. How do you guys determine what you're looking for? Where does that come from?
Yeah, you can't really boil the ocean, right? Right? You have to pick on certain. So we actually started, what happened was the data led us to looking at, well, we saw an increase in duplicate MRMs. So something so simple as that, when we became an enterprise, we started to look at what was the reason for an increase in duplicates. And then when we dug into the data, we found that too many people had access to creating, you know, medical record numbers. And, you know, City of Hope, we don't have an ER, so we're very unique in that way. So everything is controlled. The patients that come in our door are very controlled. We have a process, but we found that process was broken when the community sites became part of the enterprise. So that's how we found out. That drove us to do that report, to dig into the duplicates. And one thing led to another. We, you know, research would say, look, we're finding some issues with self-reported demographics like the patient's race and ethnicity, and it doesn't match the form that we actually have the patients complete. And we call that our self-reported demographics form. And when the patients come in the door, they complete this among other types of registration forms. And our goal is to get 99% of the patients to complete this form, the new patients. And so it's a form that they complete on paper, and then the registration person will enter the demographics that are self-reported into the system. When research does their work, they find, and they actually were doing some audits in their work, and they found that what was entered in the registration system didn't match what was self-reported. That led us to doing an extensive audit because the research team can't, and they're not equipped to do that. So that's how we basically started our process. And then we started getting requests as well. Can you look at these things? And, you know, so that's how we do it. So some internal and some requests.
How many audits do you do in any particular year, do you think?
Last year we did 28.
28, wow. And how big are these audits and how long do they take to accomplish?
Well, they can be big because we're doing it for the entire enterprise. So we don't just focus on the medical center. We focus on so they're quite extensive. And in terms of volume, we try to do 5% of whatever population that we're looking at.
5% of the population. Interesting.
Yeah.
I remember my notes that, in fact, you mentioned it earlier about the philanthropy section, how they will want to make sure that they would track whether a patient was still was not deceased or whatnot, so they didn't reach out to the family.
Right.
And that was an interesting how you had an opt-in, opt-out sort of audit to check
Yes.
they were part of the mailing system too.
Right.
That's it reminded me of something that Tara's organization Sutter Health is doing, where they're actually tracking the dates of death from all kinds of external sources.
Yes.
In fact, I'll let Tara tell it briefly. Tara, you see that relationship between what City of Hope is doing?
Out with a third-party company, and they pull data from the SSA death master file and California death records, obituary data. They also use fuzzy logic, and we get a report every week that feeds into our Epic system, and it marks the patients as deceased. And that way patients aren't erroneously registered when they're deceased. We take the patient out of our marketing and our reminder letter generation so that the family doesn't have to deal with mail from their deceased loved one. And we also are making a real effort to stop medical ID theft from using deceased patients' information to get health care.
I found those two parallels really, really cool because I haven't seen a lot of folks use the external data, and we'll talk more about that in Tara's section for sure. But
Yeah.
awesome, awesome.
Yeah.
And my last question for you is, if you were to characterize the win for City of Hope or other hospitals to have this formal audit process, what's really the big value for this? Can you articulate it?
Well, the value is seeing the data improve and giving the all of the stakeholders that peace of mind that somebody's actually looking at the data and somebody cares about the accuracy of the data, right? And somebody's trying to do something about it. And prior to us doing this, we would hear from individuals in research, in philanthropy, and some people in patient care that say, that would tell us, we have to get this data right, because if the patient wasn't expired in the system and we had the death notification sent to us and it wasn't updated, well, why not? So things like that. So people were just frustrated, and now that we have this very large multidisciplinary team in our RIG committee, people really do feel I guess comforted that we have a process in place.
Awesome. You just said something that's going to take us to Larry. He's next up anyway, but you had talked about the visibility of the data quality and how important it is for others to understand it and see it improve. And it really reminds me of something really cool that the Pomona Valley Hospital Medical Center was doing too.
Oh, thank you. So here at Pomona, we developed our data integrity team. And our data integrity team is responsible for ensuring that the data within our medical record is as up to date and valid as possible. The data integrity team reviews overlays, merges, name changes. And so the team consists of 6 individuals, 3 of which are specialists and 3 of which are technicians, and they're managed by one manager. The specialists handle the more difficult and task-oriented issues, and the technicians who are non-credentialed support them in their efforts in getting the information done.
You told me about your really awesome program of looking at every single record, looking for evidence of overlay data.
We have a couple of ways of identifying overlays and merges. It's a 2-step process. Or 2-step, process. First, it's reporting. We have reporting where we look at 2 different reports. One is the HIM EMR encounter report, and these are all patients who are registered within the ED. ED is our biggest challenge and where most of our problems come from. And so we have that list ran daily of every patient that has been registered in the ED. And the data integrity team goes through that and validates that each one of those patients registered was registered appropriately, and that there is no duplicate medical record or that they were overlaid on another patient.
Wow.
And the other report using that is the missed encounter reason. So if a patient is registered and then there is a reason why the encounter was missed, we look at that to try to determine if, oh, it was identified that the patient was seen under another name and or medical record number. And the second part of the process is research, and that's all about HIM data integrity team looking at records and identifying potential duplicates. In that research, it could be, we don't, and what I got a good idea from Adrian Beauvoir, thank you very much, is the auditing and coming up with a algorithm or some way to identify a population base. Because right now we do it based upon roughly about 10% of patients seen in a month. But we are a very busy facility, so we see a lot more than that. But the missing encounter or the research portion of that is that HIM data integrity is going through records looking for potential errors. And that could be demographics that are incorrect and so forth. And when they identify those things, they go further into it and research to find out if it is an overlay or a merged record. Okay, I know that's a lot to ingest at one time, but I'll take a breath and let you ask a question.
It's really cool because, I've talked to a lot of HIM leaders in California and across the country, and by far, Pomona was the most, I think, progressive in diving deep into the records, looking for it proactively, more than almost any other place I've seen. Now, Tara, when I talked to you and Marissa and Megan at Sutter shortly after I talked to Larry, it was kind of cool to see what you guys are doing, because from my memory, at least, Tara doesn't do this job specifically, but she's standing in for all of Sutter.
Right.
But from my memory is you guys are monitoring the changes in date of birth, patient name, social, and maybe other demographics, and then using that as your tip off to see if that was a record that was overlaid with new updated information. Can you comment on that?
Right. We have logic built into the background. Anytime there's a demographic change, it pops up on one of our work queues. It's either to check if it's an overlay, a merge, is it a known non-duplicate, or is it something else that needs to be researched?
Larry, you had some great quotes, man. I think of all the people I spoke to, you gave me the best quotes of anybody for like building the team. I'll throw your words back out there so maybe you can comment on them. But you said establish the team early and stack it heavily. And then you said if you need 4 people, double it, because there's going to be more work than you know. What do you have to say about that?
I have to say, because when we were building this team, my growing pains was I was like, oh, it's, we can do it with a very minor set of people. So as we started growing the team, it became evident to me that I was vastly underestimating the amount of work that's necessary to keep this going and to keep our records approach. Like I said, if you think you need 4 people, double that. Especially as we move forward in the coming years, the HIEs and so forth all coming on board and so forth. That started coming in as we started digging into it and finding out, how bad our issues were. I started needing more and more people. So even at this point in time, I still think I need to add at least another 2 to 3 individuals to the data integrity team. And again, if you think you have a workload for 4 people, definitely double that, because as you dig into it or get further into it, more and more stuff will pop up and you'll realize that you'll need a lot more individuals. So, yeah.
You had said that, and you also said something I thought was really cool. You said, understand the team and then empower them. Like you really stand behind your team when they're battling to fix things. I see.
And that's very true. And with that, what I meant by that and live by is that I think you should empower your data integrity team, give them the rights and the responsibility to go out and find out where the issues lie, making sure that the DI team has the ability to effect change in those areas as it relates to the integrity of the data. So my data integrity team does have the backing of myself, our PIC team, as well as leadership to be able to go into a department and look at workflows as well as processes. And if those affect the integrity of that information, have the ability to make suggestions. And if they get pushback, it comes back to me and I have a one-on-one with the director and we find a way to get it done.
It's related to what you were just saying about how highly visible your work is at the hospital. And you talked about your performance metrics as well for the data quality on this. I think it was the Performance Improvement Committee, and how the CIO, the CEO, the CFO, and everyone between looks at the data quality. Tell us about that PIC committee.
Okay, so our PIC committee is our Performance Improvement Committee, and we meet monthly. But one of the things was when I started the data integrity team and I started reporting that information, it just kind of knocked the socks off of everybody in the room. We did not realize how big of an issue we had with overlays, merges, and so forth. I did an MPI cleanup and I shared that information with them. And during our MPI cleanup, we end up looking at over 300,000 records. And out of 300,000+ records, we end up merging over 150,000 of those records.
Wow.
So this is because we've went through 3 to 4 iterations of EMRs. And during that, no one ever cleaned up the MPI. So that really piqued their interest and they were like, well, what else are you finding out there? And so reporting more and more information, we give monthly reports on the number of overlays, number of mergers that we identified by department.
Okay.
From me all the way up to the highest level, the CEO looks at this information because we want to make sure that the integrity of our information is where it needs to be. And as CHIA's policy, trusted information, we want to live by that.
No, I was just going to add, Jim, we actually have a reporting structure just like that with the RIG going up to a steering committee, going up to QA and I. Oh, so our data is actually reported because you have to have the visibility of that. So I don't know if you and I have talked, because I think it's been a while since we've talked, right? So, but that is really critical, and so it's nice to hear from Larry that he empowers his team to reach out. We reach out through the RIG, and that's how we funnel the information. But it's really critical to have that feedback, that formal feedback.
That's great, Adrian. I didn't know City of Hope was doing that. But what I found that a lot of organizations, the data just kind of dies at the HIM department. No one's looking at it to change it.
Yeah.
I'm so glad to see you guys do it too. That's amazing.
Oh yeah, no, otherwise it would be kind of futile. So we've got to have that visibility all the way up through your vertical and then across the verticals because it impacts so many things.
I'm going to pick on Marilyn a little bit now because now if you guys think I'm nerdy, just Marilyn and I are kind of two birds of a feather. So you have to put up with 2 of us on this call. But Marilyn, I got to tell you, what you shared with me was so fun. And I share our conversation with a lot of people, the concept anyway. But Adventist Health, I think, is doing something, one of the most unique things I think I've seen in the market. And before we get into it, at least, welcome to the panel, Marilyn. I'm really so happy you could join us. But tell us about your data integrity team first before we get to the big idea.
Okay. Well, thanks for having me. I appreciate the opportunity to share our workflows and what we've identified. I was working in IT in 2013, and we brought this application on board, and it was to move us from MPIs to EMPIs. We have over 20 hospitals and over 300 clinics in Northern California, Oregon, and Hawaii. And we were moving everybody to one model. So standing up a team, training the team, training the team that I oversee, we develop, we do the merging, we monitor the overlays, and we started out with 15 million records. And so in the beginning, we had a big team, and we've kind of carved it down as we've cleaned things up over the years. We're habitually having to readjust the workflows depending on third-party applications and what they do with the merge messaging. So we often have to do a deep dive into why suddenly the system is causing these errors, and we work with IT with testing and coding. And so my team, I have 5 members on the team, and I'm the manager over the team, 2 senior analysts. One works with the team and ensuring workflows are followed, and the other does a deep dive in the analysis and works with IT and testing and what have you.
One of my favorite outputs that you described from your team was it's the top 10 offenders. Do you remember telling me about that?
Yes. We started, the CIO of corporate wanted me to publish a report of the 10 top offenders who make the most duplicates in a week. And I published this report. So I extract the data out of our EMPI application, and I send it to all the directors and managers and leadership in our enterprise of the people, how many duplicates. We have pivot tables on there. They can click on their own hospital. They can identify by department, and then they see the name of their user who created the duplicate. And then there's a tab that is uniquely top 10 offenders. So across our enterprise, the 10 people who created the most duplicates in the week is published. And I tell you,
Wow.
some people push back a little bit because our database does not contain financial information. It's a database for people. It's subscribers, patients, and guarantors. It doesn't hold encounter level details. So some of the staff would get fussy and say, well, which one did I create an error on? Which one? They'd want those details. So our managers got a little savvy and said, if your name appears on this list, because they would have to go into the EHR, run a query, and find the encounters they registered. So they just made it suffice. If your name's on this, there's an issue with your work. So our error rate, since we moved to this model, did I talk about the A19 bumper guards?
That's my next question.
Okay. So
But you may if you want to, because we're going to go there anyway.
So wherever the user is sitting in a chair, regardless of clinic or facility in our enterprise, they do their person search. And if it doesn't return, it does not allow the user to add the person until they search our EMPI. And so then it triggers an A19 HL7 message, which is a patient query. It sends it out to our initiate application, and it returns a variety of algorithm based on the search criteria. So if it's all the Marylands and all the same date of birth, maybe different last names. But anyway, they return a subset of records, and the registrar can select it then. And if it's in the database, they get an error message saying, go back and do a better search. This person already exists. So it pushes them back to do a better search. If they still can't find the patient either way, then they're allowed to add the person. So with this IT solution, that's what I call the bumper guards, because it just kind of forces the registrar, because they fast, they go through systems fast, they're not as the illustration was, like L or Larry or whatever, the system doesn't allow that type of registration the way it's set up. And so, yes, they should get ID. Yes, they should verify their patients, but they don't. And it is about throughput, you know, and so they're just trying to jam through it. Frequently, they don't even understand how the fields in the registration corresponds downstream, why we capture this information because of the impact downstream.
Does anybody else have any kind of top 10 offender list or feedback to the registration departments?
I will say at Pomona, we do. We send the information back to the director of registration as well as the CFO, and it does identify the top offenders by unit and individual. And the purpose of that is for the director to find out why that keeps occurring and put the corrective actions in place.
We do as well at City of Hope, but we don't go down to that level unless the director or manager of that area will ask for it. But we go down by site too, so we know which site has the most errors. And you know, it's very interesting. It's a little bit of a competition.
Yeah.
Let's try to improve our data.
You speak of the sites, Adrian. When Marilyn and I were talking, I was sharing with her, I was talking to Kamar and a bunch of other leaders in industry, and we were talking some certain locations just have more errors than others. And we were thinking, how can we check their input before it gets to the EHR, before we have that duplicate or overlay?
Oh, yeah.
And then I found Marilyn about a few months later, go, wow, you're actually doing that. She has the EHR, which has its own search.
Right.
Then she's got an outside third-party application that matches patients and an EMPI tool. And together they work to double check each other to make sure there's not the patient already existing before they're entered. It's the most brilliant thing ever. I really love it.
Yeah.
And our error rate well, we've had a lot of vendors come in, try to sell us different tools, and they say, well, we can reduce your duplicate rate. And we say, okay, it's 0.5. They stop talking. They don't have anything else to sell.
Thank goodness you have that background in registration, IT, and HIM, because that's the perfect combination.
It is. And the folks that I hired come from the registration world.
Yeah.
And they understand, so they understand how it gets that way. And so often we monitor our overlays. We have an application that as soon as a record is overwritten, certain fields, algorithm is set, that we look at it. And of course, some are legit, you know, women get married and babies, you know, go from baby girls to a real name. And those are all, but then there's those true overlays.
It's really outstanding. I'm so glad you shared that bumper guard story, because it's got a catchy name, but it's amazing.
I have to say that HIM we're the custodial services, because as you said, you know, they put the data in and we end up cleaning it up.
Yeah.
So I think that HIM actually should be staffed in patient access. Right.
I would agree.
I think that's really we should actually take over patient access.
You're
Yeah.
Right.
HIMA would do that.
Right.
I'd just like to say to Marilyn, I think the idea of hiring registration is well served. I have to say that's the same thing I did, not fully, but my manager was a manager of registration. And I got her into HIM. She became credentialed and so forth, as well as one of my specialists, because again, having someone who has been in that area, knows the ins and outs, as you say, their shortcuts and so forth.
Tara is interesting because, you know, at Sutter, they've got, you know, facilities all over as well, and a really big, you know, 24/7 HIM shop. So Tara, you want to join the panel a little bit and maybe tell us about your org and maybe your role in the org specifically for HIM?
Sutter Health, you know, like Jim said, we're really big. a little under 200 HIM staff, and 19 of those are dedicated to data quality management. And they work 24/7, like I said, 365. That's the one position we never close. Most of them have HIM experience. Some are former IT analysts that we've, brought over to the dark side of HIM. And then most of the other ones are seasoned HIM professionals that decided, EMPI cleanup, data quality is what I like, and decided to move into that direction.
We talked a little bit about overlays at Sutter and how you guys monitor them, but I also remember you guys had a reasonable amount of metrics that you were tracking on a monthly basis. But do you have any thoughts on that you could add?
We do have about 4,000 a month of overlays, and most of those, they're either the pre-reg accounts that are done when ED triages or an ambulance comes in, and the nurse that triages the patient's trying to get something into the computer so they can start ordering things. And then a lot of our duplicates come from the registration department, like you all have experienced. One thing that we do that I have never experienced anywhere else is we do concurrent overlay corrections, and we get those done within 24 hours. We don't wait until the patient's discharged. If we have a patient that was registered incorrectly and then they go up to, say, ICU, as soon as our team gets the ticket, and of course those are always stat, they get right on it. Sometimes it might take an entire 8 hours to get it corrected, depending on how many orders have to be moved, how many contact moves have to be done. But we resolve the overlay within 24 hours.
Tara, this is Larry.
Yeah.
Can I ask you a question? So do you do your overlay corrections for patients in-house as well?
Mm-hmm.
And if so, what is your experience with regards to blood bank?
What we do is, while the patient is still being treated and our team in the background is doing their stuff, we have them continue to chart on the incorrect patient and continue to deliver that care. And as we do the contact moves, we grab that data, like say from the blood bank, and we work with the blood bank to make sure that we get the labels changed if anything is scanned in, like the monitoring and the confirmations and that type of thing. We work with the blood bank system. They use SunQuest Lab. We have analysts there. We have analysts, downstream, just like in supply chain, that account for the blood we use if we're talking about blood bank, so that at the end of the day, once everything is completely and totally moved to the correct patient, you can see in the blood bank, this is what the patient was registered as, this is how we treated the patient, but this is really who the patient is, and this is why we fixed it in our blood bank data system.
This might be going back to my conversation with Diane. I'm not sure, but somebody on this panel, I think the registration department started to use phone numbers as the
Me.
Is that you, Tara? Okay.
Yeah. When anybody gets registered, whether it's, an ED, an urgent care, or you walking into a clinic, the registration staff says, have you ever been here before? Yes. Tell me your phone number. And then they type in the phone number, and they can pull up, here's the 5 patients with this phone number. And then they can say, okay, what's your name? And then they find, okay, there's one Tara with this phone number, what's your date of birth? And then they match it that way. But we find it's quicker and more efficient, because in this day and age, almost everybody has a cell number.
Mhm.
I've been thinking about that quite a bit, because we're waiting for this national patient ID, or the universal patient ID, to become law, if it ever does, or to be funded at least. And you think about it, the cell phones and emails are probably 2 of the most unique pieces of data we have, except for our social. And so I'm kind of glad to see registration departments moving in that direction, to use different data other than first and last name which is
But
not.
the search criteria has changed dramatically. Education department, yeah.
What do you guys search for typically, Maryland, when you're registering patients?
They'll use phone number. They
Uh-huh.
can by MRN and Social Security all in one field. Every field is considered a separate search bucket.
Cool.
It's not you're back in the day it was name and date of birth and maybe gender. Now they can search by phone number, MRN, but who knows their MRN. But if you were doing it, if you were an internal person, you would have the MRN.
Yep.
Right. And then we on our side, we have built it in so that there's also, we can have a AKA, so that if we look up, I'm going to pick on you, Jim. So if Jim comes to Sutter and he says, you know, I need to receive care and I want to be registered as Jim Hoover, and he's been here before, we can say, well, Jim is actually James, JJ, Jim, and we can find him no matter how he wants how he presents, as James Hoover is his legal name. We have the AKA field as a searchable field.
That's cool. It reminds me, I'm going to bring Diane to the conversation because she had this great big idea of know your patient, know your customer, kind of similar to the financial world, where you must have an ID and a social security number so they can make sure that your funds are what they are and not coming from nefarious sources and whatnot. But Diane and I got into this conversation of knowing your patient. How can we do something that's analogous? But before we get into that, just tell us a little bit about your data integrity team and what the good work Tim Pierce and his team's doing.
Okay. First of all, we actually started a MPI cleanup before we transitioned to our new AHR, which was going to be deployed across the entire Department of Public Health. And prior to that decision that was made in 2017, every program had their own one-off systems, and a lot of the programs had their own master patient indexes. So by the time we ready to go live, we were able to get our duplication rate down to about 1%. And then with some of the additional tools after we went live, does that second ping if they cannot find it in the initial search that happens. And I think that helps slow down the process just a little bit. So we were down to 0.4% duplication rate. And then I think the other point that creates some huge challenges when you're dealing with a county system that has been charged by the county through funding and other means to keeping the population safe. Some of the things that I've been able to put in as stop gaps in registration in other organizations I've worked at, we try not to do that because the philosophy is that if we cannot get people to come here because they're afraid of us knowing who they are, then that one person could go out and impact, hundreds of thousands of other people, all because we wanted to stand behind, if you don't have positive ID, we won't see you. And so we don't ask a lot of hard stop questions, and we may or may not require government ID to be seen, and we take people at kind of as how they choose to identify themselves.
Diane, one of the things I found was fascinating when we talked was how you knew actually one patient so well when she came to register, but you couldn't find the patient, and you eventually found the patient through the extended Epic network by talking to the doctors. And the patient had actually changed their birth date, not only their gender. Is that a story that you could recount for us? It's fascinating how well you knew that patient.
Yeah. So the nice part about, being on the bigger system is that it does have some powerful tools. And so, the patient came in and we were actually, sought out by the provider because they did end up with a duplicate number. And the provider was very aware that this patient had been seen before. The registration area that they went through, because of the gender change and the birthday change, it became, obvious that we needed to try to get this patient in with the record because the provider was missing pieces of, the patient's history, the story, the medication reconciliation, problem list, and a variety of things. And organization, we do reach out to our providers to try to contact us as soon as they identify an individual where their record just doesn't really seem to match, or it doesn't seem to be the complete information that maybe the patient's giving them as far as history, and yet they're saying that they've been part of one of the city programs for, quite a long time.
It actually raises an interesting question, Diane, and I'm curious to the panel too. I've done an analysis once for a county hospital that survey of the number of patients that had more than one record. We always talk about duplicates and we think pairs of records. But have you guys seen, or do you see often where a patient might have 3, 4, 5 records or more?
We definitely have patients who have multiple records. A lot of the clients, and we hear this as we get to those, look to that fragmentation as a way of managing their privacy. And there has been huge concern with some of the programs that people would actually seek care at different clinics because they knew they were on separate and distinct healthcare systems. And so they would never be combined. And we've been looking at, how are we going to manage this population, because some of those programs that deal with very, very sensitive health issues, we have huge mental health programs as well as STD programs, as well as gender health programs. We don't want to lose them to follow-up because of the risk they might not only have for themselves, but to the greater population. And, those have been really heavy conversations, because they do change birth dates, they do change names, they do change genders, and they do it purposefully versus, it just being a registration error. So we are actually looking at how do we protect those individuals so that when they go to those different areas that we know they have one record, but they still get the experience of being able to be separate and distinct.
That's a great answer. There's so many more questions I would like to ask all you guys, but we are coming up on the top of an hour plus. Again, you guys have been a really wonderful panel, and it was just awesome information to share with the CHIA community and the world at large. Adrian, Marilyn, Diane, Tara, Larry, you guys are fabulous. Thank you guys so much for joining the panel and all the information.
Thank you for inviting me.